This is one of the most important and most discussed topics in ICL surgery. It's a topic Dr. Nasser and I will be expanding on in the future, but for the sake of completeness of this curriculum for now, we wanted to provide an introduction to ICL sizing.
First, ICL sizing has never mattered less with EVO ICL, and we encourage surgeons to avoid treating vaults similar to the predicted post-op spherical equivalent. It isn't a strict, narrow target for an optimal visual acuity outcome. Instead, it is a tolerable range of values that allow for a safe clinical outcome most of the time. However, that's not to say it doesn't matter at all, as the room for error in a specialty with high expectations is absolutely little to none. We'll review the major sizing methods and some important tips.
When using Stella to order the lenses, there will be a DFU recommendation based on white-to-white measurement. This is the manufacturer-approved method. It was originally obtained using the orb scan, however, many surgeons use different diagnostic modalities such as the Pentacam or IOL Master. 12.6 and 13.2 will comprise the overwhelming majority of lens sizes. 12.1 is generally used more than 13.7, and the times EVO will bite is when not using one of these extreme sizes when you should have.
This is all there is to say about sizing using white-to-white, because while this works the majority of the time, the sulcus anatomy is complex and highly individual, so it's important to consider looking beyond white-to-white. The LASSO formula uses a machine learning-based algorithm that takes multiple measurements and is a good way to double-check sizing in the absence of more advanced imaging. It can be used with the IOL Master and/or the MS-39. More advanced imaging would include ultrasound biomicroscopy, including ARC scan, Absolu, or SonoMed. Using the ARC scan, one of the most accurate nomograms is the London Vision nomogram. It relies on a series of caliper measurements from the ARC scan and provides vault predictions for each lens size.
The SonoMed and Absolu are other options for UBMs. The Parker's nomogram relies on caliper measurements of lens rise and sulcus to sulcus, obviously a critical measurement as this is where the lens is sitting. The newest image-based nomogram on SonoMed that involves automated measurements is ICL Guru from the Zaldivar group. A unique aspect of this nomogram is that it incorporates predicted angles as well, which is important especially in borderline cases. This also provides an ideal vault prediction and allows the selection of sizes, again based on the combination of post-op vault and angle prediction for each size.
Everything has pros and cons, of course. UBM is not as desirable from a premium patient experience standpoint, as generally it involves a lot of water, weird noises, and can be uncomfortable. The learning curve for staff is also steep. In our experience, we've had great results with UBM as it offers a more holistic view of relevant anatomy.
The last major sizing method is Gestalt, or gut feeling. We found that artificial intelligence-based sizing is generally more accurate than any Gestalt and even in shallow ACD. It's important to trust the sizing method, especially if used consistently. Of note, these are our personal experiences and may not be generalized across the globe.
Without advanced imaging, here are a few of the Gestalt tips we've learned. Number 1, avoid volatility in diagnostics. Trust the diagnostic modality and nomogram you use once optimized for your outcomes, and use the same one consistently. 2, hedge up in size on torics to create a more snug fit for the ICL in the sulcus space and prevent rotation. 3, larger ACDs can usually tolerate larger ICLs. For example, a 3.7mm internal ACD can tolerate a larger vault compared to a more shallow ACD. 4, if a single value is the most important, it's probably sulcus to sulcus in our experience, and 11.8 seems to be a reliable cutoff for 12.6 versus 13.2.
Lastly, there's some question about if you can make intraoperative sizing decisions, and we believe the answer is no and have a case to demonstrate it. This is a patient who converted from PRK to ICL on the day of their PRK. They really wanted both eyes done at the same time. The ACD was 2.55 and 2.59. Normally we would do this case one eye at a time, but with all the advanced imaging available, I felt confident about both eyes the same day. Both London Vision and ICL Guru suggested 13.2 would be totally safe even with this ACD. For ICL Guru, this 12.6 in the undervault area here made me a little more cautious, so the plan was to proceed with the 13.2s in both eyes. Here is some intraoperative video. If you notice, it just feels like this lens is large. It had a tendency to kind of pop out from behind the pupil and was difficult to initially tuck. For the second eye, the 12.6 was chosen since all the nomograms also confirmed this would be safe. On the first day, vault is as follows and is totally fine in both eyes. Vision is excellent and this outcome was fine.
This case really emphasizes a few things. For one, most eyes are realistically going to accept either 12.6 or 13.2. EVO is just that tolerant to a range in vault and range in sizes. Secondly, there's too many variables like OVD behind the lens, stability of the eye, and so forth that make deciding a lens is too big or too small inaccurate during the actual surgery. Even with intraoperative OCT, the ICL still likely has OVD behind it and hasn't settled into physiological place. Finally, trust the nomograms, especially the newer image-based ones. They are likely more accurate than Gestalt.